Well, I think these guidelines, and there's several different types. There's now the Joint Task Force guideline, which is the Joint Task Force is made up of the American College and the American Academy of Allergy, and we have practice parameters. The practice parameter for angioedema is in press as we speak. At least it's been resubmitted to the Journal of Allergy Clinical Immunology, and we anticipate that it'll be accepted and will be in press shortly. This is a guideline which really is evidence-based. It's actually addressing all aspects of angioedema, a broad differential diagnosis, the approach to the acute and chronic treatment, in-depth overview of hereditary angioedema, ACE-induced angioedema, idiopathic angioedema, and the treatment options, and with algorithmic approaches and so forth. So these are important because they help create awareness for physicians who may see these patients and have to treat them. They give the guidelines on how to treat them and so forth. So it's not really giving people guidance on the specific therapies, on how to use them, but they certainly have all the information they need to know about the therapies and make educated decisions on which patient would be best suited to one versus the other. The ICON guidelines is an international consensus guideline, which is now an impetus for the American Academy, the American College of Allergy Immunology, the European Society Allergy Immunology, and the World Allergy Organization to develop a document that helps, again, create awareness and some form of consensus approach to evaluation, diagnosis, and treatment options. Again, not really telling people specifically which drugs they should use first and when, but giving people the information. Again, creating awareness and trying to develop a consensus. There's certainly a lot of unmet needs in terms of diagnosis, point of care testing that could help clinicians in the emergency department, a patient who presents with acute abdominal swelling, to see if it's bradykinin mediated, or due to some other cause. There's certainly, again, increased awareness, not just to the allergy community, but to other subspecialties, to primary care physicians, to lay people, and so forth. So I think, emergency room department doctors, gastroenterologists, all of these are important populations, medical populations that need to have increased awareness of this condition. And then access to care, access to to centers of excellence where individuals can at least consult, physicians can consult regarding patients that they suspect might have hereditary angioedema or other forms of not as well-defined angioedema. So there's a lot of areas which I think are certainly unmet. And again, how we use these therapies down the line, how patients are, who should be receiving what drug, what constitutes a patient who really does need prophylactic therapy versus on-demand therapy. So I think all of these things are things that the practice will, and the management of these patients hopefully will give us some information as we move forward. In the recent consensus panel that was sponsored by the Hereditary Angioedema Association, they got together to discuss what we know about type 3, so to speak, and they agreed that they now want to rename this condition hereditary angioedema with normal complements with and without a genetic abnormality. That genetic abnormality has been associated with factor 12 gain of function, although they're not entirely clear it's a gain of function, but some type of factor 12 abnormality. Unfortunately, that's only been identified in about 20% of patients. So they did come out with some very reasonable recommendations that these patients should have before actually assigning such a diagnosis. They should have a strong family history, or in the presence of normal complement, they should have either a strong family history, they should have not responded to high-dose H1 antagonists, antihistamines, and they again need to have obviously appropriate swelling and so forth. But it's not a lot of really substantive, it's all clinical based, it's all We don't have a lot of science to support this. It's all the best we can do in our characterization of these patients. So by all means, we need more research to understand not just this hereditary angioedema with normal complement, because this could be idiopathic angioedema. We have to understand, what's turning on the contact pathway when patients don't have a genetic deficiency or a functional abnormality of C1 inhibitor. I think that this is a great time for hereditary angioedema patients. We certainly have come a long way from just 10 years ago, where individuals really had no recourse when they had acute attacks. We had androgens, which have some efficacy, but again, there's untold side effects, and not everybody is willing to take them. I think there is a consensus that if you are on less than 200 milligrams a day, that it's relatively safe. But even then, there's pushback from patients. At that time, when someone came in with an acute attack, we'd treat them symptomatically with pain. We'd try to hydrate them, and maybe give them fresh frozen plasma, which has a higher risk of viral transmission. So. Which sometimes can actually cause a rebound response, where actually instead of getting better, patients can get worse. So we had very few options, and then we just had to watch their airway and make sure they didn't close down and be ready to intubate. Now, when we have patients who actually have on-demand therapy ready, they understand it's sort of like an asthma action plan. They have an angioedema action plan. They actually know they have a sense of preparedness, which gives them so much more comfort. And they also have access to experts who can help guide them along the way. And if they're having very severe frequent attacks, they can even prevent these attacks using purified nanofiltered C1 esterase replacement therapy. So there's so many more options. Their quality of life has improved so much from, as we know, the burden of illness and the quality of life of these patients was very poor. In fact, it actually approached the magnitude of chronic diseases like asthma, depression, inflammatory bowel diseases like Crohn's. So I think that as we move forward, we're going to see that the burden of illness and the quality of life is going to improve. But we still have a long way to go to understand this disease, and I think there's still a bright future in terms of improving therapies that are currently available and developing new therapies. Well, I think that we certainly are interested in seeing the outcomes of subcutaneous studies for C1 esterase for both acute on-demand and prophylaxis. There's talks about oral treatments that might be easier for patients to use and take. I think that the hereditary angioedema patient is extremely important. I think this population that has normal complement with or without the genetic defects is extremely important. And I also think the idiopathic conditions that aren't responsive to antihistamines that may or may not be bradykinin mediated. So I see that there's a lot of people that could benefit from this research, patients.